Hi, I'm Jack Cush, Executive Editor for RheumNow. That's RheumNow.com. And this is the Week in Review as of Saturday, February the 5th. I'm going to do this weekly series henceforth to highlight the news items, the tweets and the features and blogs that may be of relevance to the practicing rheumatologist. This week we begin with a discussion of pregnancy. One of the more interesting things to come out this week was that there was a large study in Denmark and Sweden which looked at exposure to TNF inhibitors at the time of conception and whether or not that had any impact on outcomes. This large study, which was based on over 1.2 million people in the population, identified nearly 683 patients who were exposed to TNF inhibitors. The results were that there was a non-significant trend towards more congenital anomalies. The odds ratio for all anomalies was 1.32, but that did overlap 1 at 0.93 and 1.82 as the confidence intervals. The same was seen for cardiovascular defects and for urinary defects. So while not significant, it does suggest that maybe you should be concerned about this, but then again, this was an incredibly large study, a population-based study, so its results are probably quite accurate. One of the weaknesses of the study is that they did lump all inflammatory diseases together: RA, inflammatory bowel disease, psoriatic arthritis, and patients who have other inflammatory arthritides. And we know that the risk, for instance, of complications from pregnancy are different between inflammatory bowel disease and psoriasis, and also different in RA. So again, lumping them was probably not the strongest thing to do, but nonetheless is an interesting finding. Another finding which was interesting was from a JIA study, meaning what the investigators did was they looked at women who had juvenile idiopathic arthritis as a child, grew up to be adults, and then see what happened when they had their first pregnancy. Most of these were children that were treated in an era where they mainly were exposed to DMARDs and not necessarily biologics. But nonetheless, in the end, they did identify that there was a slight increase in congenital anomalies in the women who had JIA as a history. An interesting finding, and one that bears explanation on further study. If you look at any cohort of a rheumatologist that may become pregnant, it's going to be rheumatoids and lupus, and spondylitis. But actually, one of the surprisingly large cohorts are, again, children who grow up to be adults. And then does their prior exposures as having JIA mean something? Again, this merits further research. Next interesting was studies of patients with early rheumatoid arthritis. There are a number of studies this week that we highlighted. One specifically looked at comorbidities in a cohort of patients with early rheumatoid arthritis from a northern Sweden registry or cohort. They followed 950 RA patients for 5 years. And they showed that, again, a surprising number of patients had comorbidities right at the outset in the first year, but that over 5 years, 41% developed a new comorbidity, most common being hypertension, malignancy, stroke, ischemic heart disease, myocardial infarction, and even osteoporosis in up to 4%. So that was an interesting finding from an early RA cohort followed forward. Another study that we reported on was that of the impact of this new test called 1433-ADA. In the United States, it's called IDENT-RA. In Canada and elsewhere, it's called JointStat. And this is a test that is competing with, for instance, rheumatoid factor and CCP as a marker for RA. It has not yet been shown, I think, to be a reproducible biomarker, but it would certainly like to be. There is data out there showing that when you have early arthralgias with or without inflammatory symptoms but no swollen joints, having 1433-ADA may be predictive of future arthritis. In this particular study, they found that high levels of 1433-ADA in an early inflammatory arthritis cohort was associated with a lower likelihood of achieving a DAS or a CDI remission and a higher likelihood of developing X-ray damage. An interesting finding. Next is the study of TNF inhibitors and their association with cancer. This is a major concern for a lot of practitioners, and many people are afraid to use biologics, especially TNF inhibitors, in the setting of someone who has a history or current or past cancer. Again, the research continues to be overwhelming in this regard. This particular study looked at the risk of non-melanomatous skin cancer, mainly basal cell and squamous cell cancer, and followed those patients. This is a large Swedish cohort that looked at over 12,000 RA patients and matched those to the general population in a 4-to-1 fashion. In the end, the basal cell cancer compared to the general population was slightly increased, 1.22, but was not increased compared to patients who are not taking TNF inhibitors. So again, what's been seen is that RA patients are at a higher risk for skin cancer, in this case basal cell and squamous cell, but that the addition of a TNF inhibitor does not appear to increase the risk substantially. So look over this article if you have a concern about skin cancers and patients with biologics. Next was an interesting report that was first published at MedPage Today and then published at RheumNow.com on Friday, was that giant cell arthritis patients have a higher risk of serious infectious events in the first year. Specifically, when compared to a matched cohort, it was almost double the risk. The reasons for this were multiple, as you might expect. Being older in age, which defines the population, but the older you had, the higher the rate of serious infections, and then also being on steroids. And certainly steroid use is going to be greatest in a GCA population early on. So these are one of the reasons why we need to see more safer therapies, more effective therapies in this elderly population targeted disease, giant cell arthritis. You may remember at the ACR there were 2 pivotal reports on randomized controlled trials, placebo-controlled trials, showing that both abatacept and tocilizumab have efficacy. But also in those trials we did see a high rate of infections that was related to high-dose steroid use at the outset. So that's an interesting finding from this week. Next is lupus. Interestingly, we tweeted this study, which I thought was interesting, and that was that pediatric lupus patients have a much higher rate of acute pancreatitis than do adults. Maybe that's because often pediatric lupus is more aggressive. But more importantly, that when pediatric lupus patients do get a pancreatitis, they have a much higher rate of macrophage activation syndrome, and when present, it's universally fatal in the population that was studied. Such was not the case in the adults who developed the same complication of lupus, acute pancreatitis. An interesting finding. Next was a sub-study or reanalysis of the PROMISE study, where they actually showed, and interestingly, that for predictors of poor pregnancy outcomes, it wasn't anticardiolipin antibodies or beta-2 glycoprotein 1 antibodies. Instead, lupus anticoagulant was the one that was most closely associated with poor outcomes. The interesting stat of the week is that, yes, we are in an opioid epidemic in the United States, and the numbers are staggering. 44 opioid deaths per day in the United States. And what the CDC and others have shown is that these rates are higher when highest doses of an opioid are given as opposed to the lower or standard doses. So keep that in mind. Look forward to future weekend reviews. Have a great week. Watch RheumNow.com.